Alpha blocker and beta blockers are two types of postsynaptic anti-adrenergic medications that prevent their respective receptors from being stimulated by catecholamines, like norepinephrine and epinephrine. The nervous system is divided into the central nervous system, so the brain and spinal cord, and the peripheral nervous system, which includes all the nerves that connect the central nervous system to the muscles and organs. The peripheral nervous system can be divided into the somatic nervous system, which controls voluntary movement of our skeletal muscles, and the autonomic nervous system, which is further divided into the sympathetic and parasympathetic and controls the involuntary movement of the smooth muscles and glands of our organs. Now, the autonomic nervous system, which includes both the sympathetic and parasympathetic nervous system, is made up of a relay that includes two neurons. We'll focus on just the sympathetic nervous system. Signals for the autonomic nervous system start in the hypothalamus at the base of the brain. Hypothalamic neurons have really long axons that carry signals all the way down to the thoracic and lumbar spinal cord nuclei, where they synapse with preganglionic neuron cell bodies. From there, the signal goes on from the preganglionic neurons down its relatively short axon, exits the spinal cord, and reaches the nearby sympathetic ganglion, which is made up of lots of postganglionic neuron cell bodies. The postganglionic neurons are also called adrenergic neurons because they release the neurotransmitter norepinephrine, which is also called noradrenaline, and to a much lesser degree, epinephrine, or adrenaline. These two catecholamines activate the adrenergic receptors on the many different organs which allow the sympathetic nervous system to trigger the fight or flight response that increases the heart rate and blood pressure, as well as slowing digestion. All of this maximizes blood flow to the muscles and brain and can help you either run away from a threat or fight it, which is why it's also called the fight or flight response. Now, there are two main groups of adrenergic receptors, the alpha receptors and beta receptors. Let's focus on the alpha receptors, which have two subtypes, alpha 1 and alpha 2. Alpha 1 adrenergic receptors are mainly located on the walls of blood vessels, and when stimulated, they cause vasoconstriction, thus decreasing blood flow to tissues. In the eyes, alpha 1 adrenergic receptors also trigger mydriasis, or pupil dilation. In the bladder, they cause sphincter constriction and urinary retention, or holding the urine within the bladder, and in males, they trigger ejaculation. Now, alpha 2 adrenergic receptors are primarily found on the presynaptic neuron. So, when a presynaptic nerve ending is stimulated to release noradrenaline in the synaptic cleft, some of that norepinephrine turns around and binds to alpha 2 receptors on the presynaptic membrane. This inhibits further release of norepinephrine and serves as a mechanism of negative feedback control. Alright, so medications that inhibit peripheral postsynaptic adrenergic neurons are called peripheral postsynaptic anti-adrenergics. Ta-da! And based on the type of receptors they block, they are divided into two main categories, alpha blockers and beta blockers. Now, alpha blockers are subdivided into two groups of their own, non-selective alpha blockers and selective alpha blockers. Non-selective alpha blockers work on both alpha 1 and alpha 2 adrenergic receptors and include phenoxybenzamine and phentolamine. By blocking alpha 1 receptors, they cause vasodilation and lower blood pressure. But what sets these two apart is that phenoxybenzamine is an irreversible, non-competitive antagonist, while phentolamine is a reversible, competitive antagonist. So, phenoxybenzamine binds irreversibly to a different site on the receptor from catecholamines and changes the shape of the receptor so that it can no longer bind to catecholamines. This effect cannot be overcome, even if the levels of catecholamines increase. In fact, the only way out is to synthesize new adrenergic receptors, which takes about 24 hours. This makes phenoxybenzamine perfect for the treatment of pheochromocytoma, a rare tumor of the adrenal medulla which secretes too much of the catecholamines, adrenaline, and noradrenaline. On the other hand, Phentolamine competes with catecholamines for the exact same binding site on the receptor, but it's reversible, meaning that it can be kicked off after a while, especially if there's a lot of catecholamines around. Now, phentolamine can also be used in pheochromocytoma, but it's mainly used to treat hypertensive crises caused by a combination of a monoamine oxidase inhibitor, or MAOIs for short, and tyramine-rich food and drinks, such as cheese, wine, and beer. Okay, so since alpha-1 receptor inhibition causes vasodilation, we get side effects like hypotension, headache due to vasodilation in the brain, and nasal congestion due to vasodilation of nasal mucosa. In men, it can cause difficulty in ejaculation due to alpha-1 receptor inhibition in the seminal tract. When blood pressure drops, the body compensates by increasing the heart rate, leading to tachycardia. Now, remember, these medications also inhibit the alpha-2 receptors on the presynaptic neurons, which normally regulate catecholamine release through feedback inhibition. This leads to uncontrolled catecholamine release, which also act on other receptors like the beta receptors in the heart, causing it to beat even faster, which could worsen the tachycardia and turn it into an arrhythmia. Alright, now selective alpha blockers work on either alpha-1 or alpha-2 adrenergic receptors. Alpha-1 blockers mainly include prazosin, terazosin, doxazosin, and temulosin, so they all end in osin. By blocking alpha-1 receptors and inducing vasodilation, prazosin, terazosin, and doxazosin are effective in lowering blood pressure, so they're used in cases of hypertension. Once again, there's a risk of causing hypotension, especially when given for the first time, and tachycardia through the baroreceptor reflex. These side effects are less severe compared to non-selective alpha blockers, since the negative feedback inhibition through the alpha-2 adrenergic receptors is still working. The rest of the side effects, though, such as headache, nasal congestion, and difficult ejaculation, are still present. On the flip side, temulosin is much less effective on alpha-1 receptors found in blood vessels. Instead, it's selective for a specific subtype of alpha-1 receptors called alpha-1A, found in the smooth muscle of the bladder neck and the prostate itself. So it can be used to relieve urinary retention in cases of benign prostatic hyperplasia, or BPH for short, where the prostate is enlarged and might obstruct urine flow. Despite its specificity, temulosin can also cause relaxation of the iris dilating muscle and has been associated with intraoperative floppy iris syndrome, or IFIS for short. This is when the iris prolapses during a standard cataract surgery. On the other hand, there are no commonly used peripheral selective alpha-2 blockers. The main medication that inhibits this receptor is mirtazapine, which works in the central nervous system. It's an atypical antidepressant that works by inhibiting the alpha-2 receptor, which increases the release of serotonin along with norepinephrine. Now, we want to make a simple and fun mnemonic that will help you efficiently memorize and retain all of these crazy farm facts. Let's have a highway with 2 lanes, where the top lane has the word alpha-1 on it, and the bottom lane is alpha-2. The line in the middle of the street is where we put the 2 non-selective alpha blockers. We have a phoenix driving a Benz for phenoxybenzamine, and it's running over a bird that's half crow and half phoenix, since it's ideal for pheochromocytoma. Also on the line is phentolamine, which is represented by the Phantom of the Opera. He's taking wine and cheese from Chairman Mao, which represents MAOIs and tyrosine-containing foods that, when combined, could cause hypertensive crisis. Next, farther down the road on the alpha-1 side, we have a sinful devil with a big O on his chest for some of the medications that end in osin. He's holding the leashes to his pet duck for doxazosin, a pterodactyl for terazosin, and a parrot for prazosin. These 3 are sitting on a blood vessel to help you remember the main target for these drugs. On the other side of the devil is a urinal with a discarded tiramisu cake for temulosin, which is mainly used to treat urinary retention in BPH. Now, under the alpha-1 area, The alpha-2 side of the street is blocked off with traffic barriers to help you remember that there are no clinically relevant medications that are selective for alpha-2 blockers in the peripheral nervous system. Now, for side effects shared by all alpha blockers, let's use a group of joggers. Running along the middle line, closer to the non-selective alpha blockers, is a heart wearing a sweatband to help you remember that tachycardia and arrhythmia are more common with these drugs. Next is a guy with a runny nose, wearing nothing but his sexy shorts for nasal congestion and sexual dysfunction. Finally, there's a guy who got orthostatic hypotension and passed out in the street. For drug-specific side effects, the tiramisu cake has an iris flower growing out of it to represent intraoperative floppy iris syndrome. Alright, as a quick recap, alpha blockers are divided into non-selective blockers, which include phenoxybenzamine, an irreversible antagonist mainly used for the treatment of pheochromocytoma, and phentolamine, a reversible antagonist mainly used to treat hypertensive crisis caused by the combination of monoamine oxidase inhibitors, or MAOIs, and tyramine-rich foods. Selective blockers are subdivided into alpha-1 blockers, including prazosin, terazosin, and doxazosin, used in hypertension treatment, and tamulosin, which relieves the symptoms of benign prostatic hyperplasia. But wait, there's more! Here's a mind map with all of the mnemonics. Go ahead and pause the video so you can test yourself to see what you remember. Stay tuned for the answers after the credits.
Alpha blockers and beta blockers are two types of postsynaptic anti-adrenergic medications that prevent the respective receptors from being stimulated by catecholamines, like norepinephrine and epinephrine. The nervous system is divided into the central nervous system, so the brain and spinal cord, and the peripheral nervous system, which includes all the nerves that connect the central nervous system to the muscles and the organs. The peripheral nervous system can be divided into the somatic nervous system, which controls voluntary movement of our skeletal muscles, and the autonomic nervous system, which controls the involuntary movement of the smooth muscles and glands of our organs. This system is then further divided into the sympathetic and parasympathetic nervous systems. Now, the autonomic nervous system is made up of a relay that includes two neurons. We'll focus on just the sympathetic nervous system. Signals for the autonomic nervous system start in the hypothalamus, at the base of the brain. Hypothalamic neurons have really long axons that carry signals all the way down to the thoracic and lumbar spinal cord nuclei, where they synapse with preganglionic neuron cell bodies. From there, the signal goes from the preganglionic neurons down its relatively short axon, exits the spinal cord, and reaches the nearby sympathetic ganglion, which is made up of lots of postganglionic neuron cell bodies. The postganglionic neurons are also called adrenergic neurons because they release the neurotransmitter norepinephrine, which is also called noradrenaline, and to a much lesser degree, epinephrine, also known as adrenaline. These two catecholamines activate the adrenergic receptors on many different organs, which allows the sympathetic nervous system to trigger the fight-or-flight response that increases the heart rate and blood pressure, as well as slowing down digestion. This response maximizes blood flow to the muscles in the brain and can help you either run away from a threat or fight it, which is why it's called the fight-or-flight response. Now, there are two main groups of adrenergic receptors, the alpha receptors and beta receptors. Let's focus on beta receptors, which have two main subtypes, beta 1 and beta 2. Beta 1 adrenergic receptors are mainly located in the heart, where they increase the heart rate and contractility, which helps pump out more blood. Beta-1 receptors are also found in the kidney, where they stimulate a very special kind of cell called juxtaglomerular cells to release renin. Renin is part of the renin-angiotensin-aldosterone system, which increases sodium and water retention by the kidneys and helps increase blood pressure. Moving on to beta-2 adrenergic receptors, these are found on smooth muscle cells in the walls of blood vessels supplying skeletal muscles and the brain, which leads to vasodilation and increased blood flow to these tissues. In the lungs, beta-2 adrenergic receptors cause bronchodilation, and that increases oxygen delivery to cells. In the gastrointestinal tract, they decrease motility and slow digestion. In the eyes, they act on the ciliary body to promote the secretion of aqueous humor, which provides support and helps maintain the shape of the eye. Now, in the liver, they cause more glucose to be released into the blood. In the pancreatic islets of Langerhans, they promote the release of insulin. Finally, beta-2 receptors stimulate an enzyme found on the surface of the cells lining capillary walls called lipoprotein lipase, which breaks down triglycerides into free fatty acids and glycerol. Alright, so medications that act on peripheral postsynaptic adrenergic neurons to block adrenergic receptors are called peripheral postsynaptic antiadrenergics. And based on the types of receptors they block, they're divided into two main categories, alpha blockers and beta blockers. Now, beta blockers are subdivided into three generations. The first generation of beta blockers are non-selective blockers, meaning they work as antagonists on both beta-1 and beta-2 adrenergic receptors. So here we have propranolol, timolol, nadolol, sotalol, and pindolol. Actually, pindolol is not a pure antagonist, but a partial agonist. That means that when bound to a beta receptor, it very weakly stimulates it, but at the same time, it prevents binding and stimulation by the more potent catecholamines. This is known as intrinsic sympathomimetic effect. Or more simply, pindolol has the same but weaker effects compared to the other first-generation beta blockers. Now, by blocking beta-1 receptors in the heart, these medications decrease the heart rate and contractility, which lets the heart work less hard and pump less blood out, resulting in a drop in its oxygen and energy demands, as well as a drop in blood pressure. At the same time, beta-1 blockade in the juxtaglomerular cells in the kidney decreases renin release, which in turn decreases angiotensin II and aldosterone, letting more sodium and water be lost in the urine and lowering blood pressure even more. Okay, but by blocking beta-2 receptors as well, they also cause some vasoconstriction of blood vessels supplying the skeletal muscles and the brain. This is typically very mild though, and doesn't have significant effects on blood pressure. In the brain, in fact, beta-2 receptors in blood vessels are only reached by propranolol, which is lipid-soluble enough to penetrate the blood-brain barrier and induce some degree of vasoconstriction. Now, moving on to the lungs. Blocking beta-2 receptors causes bronchoconstriction, or narrowing of the respiratory airways, which obstructs airflow and lets in less oxygen. In the gastrointestinal tract, beta-2 blockade speeds up motility. In the eye, aqueous humor production decreases, so intraocular pressure, or the pressure within the eye, falls. Now in the liver, less glucose gets released in the bloodstream, and the pancreas releases less insulin. And finally, inhibition of lipoprotein lipase leads to the accumulation of triglycerides in the blood. Alright, so looking at the indications of non-selective beta blockers, they are widely used in the treatment of hypertension and coronary artery disease in the form of angina pectoris or a heart attack. It has also been suggested that beta blockers slow down the progression of congestive heart failure, or CHF for short. This remains controversial though, since individuals with heart failure often rely on sympathetic drive to maintain some degree of heart function. So in this situation, beta blockers might actually make things worse, especially in a situation of acute CHF exacerbation. Next, beta blockers can be used to slow down the heart rate in cases of severe tachycardia, like in thyroid storm, which is an acute, life-threatening complication of hyperthyroidism, where the body becomes very sensitive to the effects of excess thyroid hormone. For the same reason, some people use them in case of severe anxiety, like before giving a speech. Now, propranolol in particular has also been shown to effectively prevent migraines, a type of terrible headache, perhaps by altering the blood flow to the brain. And timolol helps reduce intraocular pressure when applied topically on the eye, which is why it's been used in the treatment of glaucoma. Now, side effects of non-selective beta blockers include bradycardia and hypotension, meaning that the heart rate or blood pressure may fall too low. Note also that in cases where someone quits taking them all of a sudden, they can lead to severe rebound tachycardia, hypertension, or even arrhythmias, meaning irregular heartbeat. There are also often complaints of fatigue, perhaps due to the reduced blood flow to the muscles, as well as dizziness, depression, insomnia, and nightmares, particularly due to the central nervous system effects of propranolol. Since they can cause wheezing, shortness of breath, and chest tightness, they are also strictly contraindicated in both chronic obstructive pulmonary disease, or COPD for short, and asthma. Sometimes diarrhea has also been seen. In other cases, there's hypertriglyceridemia, or increased blood triglycerides, and hypoglycemia, or reduced blood glucose levels. Hypoglycemia is the side effect to watch out for, as it may go unnoticed, since beta blockers blunts the counter-regulatory effects and symptoms of catecholamines, like tachycardia and tremors. That's particularly dangerous for people with diabetes who already take a bunch of other hypoglycemic medications, like insulin. Okay, now the second generation of beta blockers are selective for beta-1 adrenergic receptors, which is why they're called beta-1 selective or cardioselective beta blockers. Examples here include atenolol, metoprolol, bisoprolol, esmolol, and acebutolol. Like pindolol, acebutolol is a partial beta-1 receptor agonist with an intrinsic sympathomimetic activity and weaker beta-1 blocking effects. Now, once again, by blocking beta-1 receptors, these medications lower blood pressure by decreasing the heart rate and contractility, while in the kidneys they decrease renin release. This makes them suitable for the treatment of hypertension, coronary artery disease, and cases of severe tachycardia, like thyroid storm and anxiety. Their use in congestive heart failure is controversial here too, but metoprolol and bisoprolol have shown fairly good results, so they're commonly administered. Due to the absence of the beta-2 blockade, they don't cause bronchoconstriction, so they can be safely used in individuals with COPD and asthma. They don't affect blood glucose as much, so they are the preferred beta blockers for those with diabetes. Bear in mind, though, that at high enough doses, these medications may also start blocking beta-2 receptors, so these individuals should always be carefully monitored. Finally, we have a third generation of beta blockers, which includes labetalol and carvedilol. What sets this generation apart is that except for blocking both beta receptors, but with a higher selectivity for beta-1 receptors, these medications also block alpha-1 receptors in the blood vessels, which normally cause vasoconstriction. This makes them particularly useful in the treatment of hypertension, where vasoconstriction is a problem, like those with peripheral vascular disease. Labetalol in particular is the most commonly used medication for the treatment of chronic hypertension in pregnancy. And it's also often administered intravenously in hypertensive emergency, when the blood pressure becomes really high really fast, and there's also signs of end organ damage like the brain and kidneys. Carvedilol also has antioxidant properties, meaning that it decreases the production of free radicals and prevents thickening of blood vessel walls, which is beneficial in the treatment of heart failure. However, both labetalol and carvedilol have side effects of alpha blockade, like orthostatic hypotension, where there's a sudden blood pressure drop when the individual goes abruptly from lying down or sitting to standing up. Now, we want to make a simple and fun mnemonic that'll help you efficiently memorize and retain all these farm facts. Okay, since beta blockers end in lol, let's put them in the LOL comedy club. Let's set up 3 stages for the 3 generations. All the stages are decorated with little hearts with knives stabbing into them to represent coronary artery disease like heart attack. The stages all have microphones with blood pressure cuffs wrapped around them for hypertension. Okay, so the first stage is labeled beta 1 and 2 for the receptors targeted by the first generation beta blockers. On this stage, we have propranolol, timolol, nadolol, sotalol, and pindolol. So let's have a skit about a man named Tim for timolol, who's drinking a soda for sotalol. He's trying to fill his propane grill representing propranolol, but it's not going well. Frustrated, he pulls the pin on a grenade for pindolol and nadolol and decides to blow the whole thing up. Now, for drug-specific indications, Tim's so angry that his eyes are popping out, which represents increased intraocular pressure and glaucoma. On the propane grill is a mannequin head with a Band-Aid on it, since propranolol can be used to treat migraines. Okay, on the second stage we have the second generation beta blockers, labeled beta 1. Here we have an escape artist for esmolol. For his act, he's wearing a pair of metal handcuffs for metoprolol, and he's attempting to escape for atenolol. By his side are 2 other prop pieces. There's a large bishop chess piece for bisoprolol and an ace of clubs for acebutolol. His assistant is an obese man with diabetes, and he's here to remind you that second-generation beta blockers are less likely to cause hypoglycemia and diabetes. Finally, there's an angry police officer on the stage who's missing his handcuffs. He's so upset that he needs to use his asthma inhaler. This will help you remember that second-generation beta blockers can be used in people with COPD and asthma, since they don't cause bronchoconstriction. Between stage 1 and 2, let's put some disorders that can be treated by both groups of medications. So let's have a tornado with little bow ties in it to represent thyroid storm. The stagehand is watching it anxiously to represent anxiety. Okay, moving on to the final stage labeled beta 1, beta 2, and alpha 1, we have the third generation beta blockers. On this stage is a doctor in a lab coat for labetalol, and she's doing ventriloquism with a cadaver for carvedilol. The club owner is trying to wash away the smell with a hose that's shooting out red-colored water to help you remember that these are the only beta blockers that cause vasodilation, and they can be used to treat peripheral vascular disease. For drug-specific indications, the scientist is pregnant to help you remember it's the drug of choice to treat hypertension during pregnancy. Her lab coat has ER on it to help you remember it can be used during hypertensive crisis. Now, for side effects, let's use the audience in front of each stage. By stage 1, we have 2 tables labeled beta 1 and beta 2. At the beta 1 table, we have a frozen heart representing bradycardia, and a man who stood up too quickly and becomes dizzy, representing hypotension. At the beta 2 table, we have a giraffe with a neck brace to represent bronchoconstriction, and there's a bunch of empty candy wrappers to represent hypoglycemia. Now at stage 2, there's only a beta 1 table, since these medications are selective for that specific receptor. Finally, at stage 3, we have the beta 1 and 2 table, and also the alpha 1 table. The man at this table also stood up too fast and is feeling dizzy. This will help you remember that both alpha 1 and beta 1 blockage can lead to hypotension. Alright, as a quick recap, beta blockers are divided into 3 generations. The first generation are non-selective beta 1 and beta 2 blockers, which include propranolol, timolol, nadolol, sotalol, and pindolol. The second generation are selective beta 1 or cardioselective beta blockers, including atenolol, metoprolol, bisoprolol, esmolol, and acebutolol. Both first and second generation medications are used in the treatment of hypertension, coronary artery disease, and cases of severe tachycardia, like thyroid storm and anxiety. What sets them apart mainly are their side effects, since they may both cause hypotension, bradycardia, rebound tachycardia, and arrhythmias. But only the first generation causes skeletal muscle and brain vasoconstriction, bronchoconstriction, hypoglycemia, and hypertriglyceridemia. Finally, the third generation includes beta 1, beta 2, and alpha 1 receptor blockers, like labetalol and carvedilol. But wait, there's more! Here's a mind map with all the mnemonics. Go ahead and pause the video so you can test yourself to see what you remember. Stay tuned for the answers after the credits.
Peripheral presynaptic anti-adrenergics are a class of medication that's not very commonly used these days. Their mechanism of action is to target the presynaptic adrenergic neurons in the peripheral nervous system and prevent them from effectively releasing the catecholamines, norepinephrine, and epinephrine. Now, the nervous system is divided into the central nervous system, so the brain and spinal cord, and the peripheral nervous system, which includes all the nerves that connect the central nervous system to the muscles and organs. The peripheral nervous system can be further divided into the somatic nervous system, which controls voluntary movement of our skeletal muscles, and the autonomic nervous system, which is further divided into the sympathetic and parasympathetic, and controls the involuntary movement of the smooth muscles and glands of our organs. Now, the autonomic nervous system, which includes both the sympathetic and parasympathetic nervous system, is made up of a relay that includes 2 neurons. We'll focus on just the sympathetic nervous system. Signals for the autonomic nervous system start in the hypothalamus at the base of the brain. Hypothalamic neurons have really long axons that carry signals all the way down to the thoracic and lumbar spinal cord nuclei, where they synapse with preganglionic neuron cell bodies. From there, the signal goes from the preganglionic neurons down its relatively short axon, exits the spinal cord, and reaches the nearby sympathetic ganglion, which is made up of lots of postganglionic neuron cell bodies. The postganglionic neurons are also called adrenergic neurons because they release the neurotransmitter norepinephrine, which is also called noradrenaline, and to a much lesser degree, epinephrine, or adrenaline. These 2 catecholamines activate the adrenergic receptors on many different organs, which allow the sympathetic nervous system to trigger the fight-or-flight response that increases the heart rate and blood pressure, as well as slowing digestion. All of this maximizes blood flow to the muscles and brain, and can help you either run away from a threat or fight it, which is why it's also called the fight-or-flight response. Now, let's zoom into an adrenergic synapse. The presynaptic terminal contains loads of tiny synaptic vesicles, each of which store thousands of norepinephrine molecules. But for norepinephrine to be there in the first place, a precursor amino acid called tyrosine is taken up by the adrenergic neuron and gets converted to L-dihydroxyphenylalanine, or L-DOPA for short, by an enzyme called tyrosine hydroxylase. Next, L-DOPA is converted into dopamine, which is then packaged into the synaptic vesicles with the help of a transporter called vesicular monoamine transporter, or VMAT for short. The remaining dopamine will be broken down by a class of enzymes called monoamine oxidases, or MAOs for short. Okay, now once inside the vesicles, dopamine gets converted by dopamine beta hydroxylase into norepinephrine. And then, whenever the appropriate signal travels down the axon to the axon terminal, these vesicles fuse with the presynaptic membrane in order for norepinephrine to get released, or exocytosed, into the synaptic cleft and take action on the adrenergic receptors of the postsynaptic neuronal membrane. Now, each of these presynaptic neurons has small reuptake proteins called norepinephrine transporters, or NETs for short, which pump norepinephrine from the synaptic cleft back into the presynaptic neurons. Once inside the neuron, with the help of vesicular monoamine transporter, or VMAT, norepinephrine gets packaged into pre-existing vesicles, waiting to be released once more. Just like dopamine, any bit of norepinephrine that's left behind in the cytoplasm will be broken down by monoamine oxidases, or MAOs. Alright, so medications that act on peripheral presynaptic adrenergic neurons to inhibit adrenergic signal transmission are called peripheral presynaptic anti-adrenergics. What these do is collectively oppose the effects of the sympathetic nervous system. So overall, heart rate and blood pressure decrease, digestion speeds up, and the fight-or-flight response gets blocked. Okay, so peripheral presynaptic anti-adrenergics are further subdivided into those affecting norepinephrine synthesis, norepinephrine storage, and norepinephrine release. Now, there are inhibitors of norepinephrine synthesis, which include alpha-methyl-P-tyrosine, or matyrosine. Matyrosine looks like tyrosine, and it can bind to and inhibit the enzyme tyrosine hydroxylase. This means less tyrosine gets converted to L-DOPA, so down the road, less norepinephrine is produced and less gets released into the synaptic cleft. Matyrosine can be given to lower the blood pressure in individuals with pheochromocytoma. Pheochromocytoma is a rare tumor of the adrenal medulla, which secretes too much catecholamines, causing extreme peaks of high blood pressure or hypertension. The main side effect, though, is that blood pressure may fall too low, causing hypotension. Now, norepinephrine storage is mainly inhibited by another medication called reserpine. Reserpine's job is to block the vesicular monoamine transporter, or VMAT. What this means is that dopamine is prevented from getting stored into the synaptic vesicles and turning into norepinephrine. At the same time, recirculated norepinephrine from the synaptic cleft cannot get repackaged into the synaptic vesicles. Instead, both dopamine and norepinephrine build up in the cytoplasm, where they get chopped up by monoamine oxidases, or MAOs. The end result is a decrease in both norepinephrine and dopamine. This makes reserpine effective in controlling high blood pressure. However, it's almost never used today due to its poor absorption, slow metabolism, and most importantly, its long-term side effects on the central nervous system, where it causes the same depletion of dopamine and norepinephrine. This results in depression, drowsiness, fatigue, and difficulty concentrating. Alright, now norepinephrine release is directly inhibited by guanethidine. Guanethidine gets gobbled up by the presynaptic terminal through norepinephrine transporters, so it directly competes with norepinephrine during its reuptake. So essentially, more norepinephrine remains active in the synaptic cleft, causing a transient increase in adrenergic signals and thus an increase in blood pressure. As guanethidine enters the presynaptic nerve, it accumulates in the synaptic vesicles, where it displaces norepinephrine. And soon enough, norepinephrine stores get depleted. At the same time, guanethidine blocks the fusion of synaptic vesicles with the presynaptic membrane, preventing norepinephrine release into the synaptic cleft. All this leads to less stimulation of the postsynaptic adrenergic receptors, which can be useful in terms of lowering the blood pressure. However, just like reserpine, guanethidine is almost obsolete today due to its poor absorption, slow metabolism, and most importantly, its initial hypertensive effect. Okay, so now we want to make a simple and fun mnemonic that'll help you efficiently memorize and retain all of these crazy farm facts. So let's have a toy factory with 3 workers. The first worker is building a toy black cat holding a cola can for catecholamine synthesis. He's about to be attacked by a Tyrannosaurus holding a slab of meat for tyrosine. It's also snapping at a bird that's half crow and half phoenix, since it's used to treat hypertension and pheochromocytoma. The next worker represents storage, so he's packing boxes. Since the medications in this class affect both catecholamines and dopamine, let's put a cola cat and a Doberman doll in the box. He's about to be attacked by a robot serpent for reserpine. The robot serpent has a biological brain on its head to help you remember that this medication is very active in the central nervous system and could cause side effects like depression. So let's have the robot serpent cry big, sad tears. Finally, the last worker is pushing a cart full of cola cats out of the factory, which represents catecholamine release. Waiting for him is an iguana, who's ready to have him for dinner, which represents guanethidine. Let's put a pumped-up blood pressure cuff on his tail, so you remember that this drug could initially worsen hypotension as a side effect. There's also a worker who passed out from orthostatic hypotension in the middle of the factory, since all 3 groups of medication can cause this as a side effect. Due to the unsafe condition of the factory, many of the non-essential workers, like the box packer and the cart pusher, eventually quit, so those medications filling those roles, like reserpine and guanethidine, are rarely used. Alright, as a quick recap, peripheral presynaptic anti-adrenergics act on presynaptic neurons of the peripheral nervous system. Tyrosine inhibits the enzyme tyrosine hydroxylase and prevents catecholamine synthesis. Reserpine prevents the storage of dopamine and norepinephrine in the synaptic vesicles, and guanethidine blocks the release of norepinephrine in the synaptic cleft. These medications are mainly used for treating hypertension, but reserpine and guanethidine are rarely used due to their side effects. But wait, there's more! Here's a mind map with all of the mnemonics. Go ahead and pause the video so you can test yourself to see what you remember. Stay tuned for the answers after the credits.